The most difficult part is understanding that you're embarking in your lifestyle will change, your family commitments will change, your free time will change. You have to make adjustments in your life.
If you know the value of what you seek, then insignificant will be the sacrifices you'll make to achieve that goal. Sleepless nights or the time that you have to sacrifice, your weekends, will just be insignificant.
I mean, nowadays we have a crisis of attention spans with the new generation of, TikTok, social media. I'm shook for them doing the operation.
When you're getting ready to go into theatre, the most important thing is go to the toilet.
Empty everything.
Hello and welcome to the brand new episode of the StriveMed podcast, hosted by myself, Dr. Anam.
Dr. Zach.
And today we have an incredible guest. I'm so excited to go all into it. This is David Ferguson, Dr. David Ferguson, one of the Orthopaedic Registrars, and just finished a set of orthopedics, my orthopedics rotation, and he made it very, very enjoyable for me. You can find him on Instagram, Dr_D Ferguson on the screen right now. First of all, David, welcome to the podcast. Thank you so much for coming down, man. I just wanted to kind of take it back, to the viewers of how we met. And, it was actually amazing experience working with you on call. First of all, just wanted to say I'm very grateful for all the support and mentorship. And obviously, you take different lessons from different registrars, different orthopedic consultants and seniors on how they like to work, how things like to operate. And I think, when we first met, the very first interaction we had was more like constructive criticism with regards to, when working on my shift. And I think that's one of the things from that position where I was able to take on that feedback and implement it. I've really felt myself improving within orthopedics as a doctor as a whole. And for me, it was just from the mindset of, okay, this is feedback from an individual who's senior to me, who I respect abundantly, and I'm going to do whatever it takes to implement that. And I think from that position, we just had this kind of relationship of mutual respect, mutual understanding, where essentially we're working towards the same goal and we're trying to achieve excellence at the end of the day. So I think that's also something, obviously with every podcast we have, we like to take wisdoms and share wisdoms with the wider community, whether it's the medical community, surgical community, aspiring medics as well. But it was very clear to me from the very first time that we met that David is a doctor who takes pride in his work, and he often says that I'm on call. So he uses that phrase regularly, is that you're on call with me, for example. And for example, when we're presenting the next day in the trauma meetings, he takes pride in performing the excellent execution, excellent presentation, and he takes pride in his work, essentially. That's some very, very important quality to have. And David, obviously, this is my best friend since university. Zach, Dr. Zach.
We haven't met formally. Obviously, this is the first time I meet you. I've seen you around in the hospital.
Yeah.
It's been on a few on calls and I've seen you here and there, but it's good to finally meet. And obviously, I just wanted to, I echo Inam's statements. He's mentioned a lot of things about your leadership as a registrar. And I think it's good to obviously, especially as a junior, you need that sense of leadership and you need that guidance, especially when you're starting out. But I also wanted to commend you on the fact that you're here on a weekend. It's already busy and it's busy enough having being a registrar and, having a busy schedule, especially with surgery on calls and stuff. So the fact that you're taking your time out, to come all the way to just, sit down with us and have a chat, I thank you a lot for that. Thank you for coming onto the pod.
Thank you for having me, guys. What you've been doing is amazing. It's really enjoyable to follow your story and the podcast. And when you invited me, I thought great opportunity. Yeah, absolutely wonderful. And going on from what you said, it's a pleasure to work together. I think we started on a weekend on call. Right, and that's one of the most stressful times. Yeah. The bosses are around. Sometimes they're not immediately accessible, and you have to run things and own the department and what we're doing. So it was interesting, our first shift, and then we just grew from there, and it was fantastic. And one of the big things, we may touch on it, is being able to help teach people and watch them grow and develop. It's so rewarding.
I love that. Honestly, I'm very grateful for that. And to be honest, every individual, has a unique style. And to be honest, that resonated very much with me, that direct nature, that direct form of communication, whereas sometimes those are the most reliable people. They're not going to go around behind your back talking nonsense at the end of the day. But at the end of the day, if there's something, okay, let's chat about it, this is the best way we want to go forward, and we grow from strength to strength at the end of the day.
Absolutely.
That's really the way it should be.
Yeah. So to start off, David, like we especially with guests that we're not, obviously I'm not too familiar with yourself, so we do a little icebreaker activity.
Okay.
And obviously for the viewers, it'll be good as well for them, beneficial to get to know you a little bit more. So we're just going to ask you a set of questions. Sometimes we do rapid fire questions, but obviously for these, like, you can take as much time as you need.
Okay.
So the first question to start off is, obviously being in surgery, what's the longest hours you've worked in a week? Would you say?
Probably, if we're looking at just what you're supposed to do at a hospital, probably 80 plus. But then you add in the other stuff that people don't necessarily talk about, the logbook, the other bits and pieces that you have that you need in order to operate. And yeah, it's 80 plus sometimes.
Wow. That's a lot of hours, man. I think the longest I've touched as a junior is probably, I don't think I've gone beyond 60. Yeah.
And you feel it, right? When you do that, or you do that amount, gosh, you realize it's not sustainable the whole time, that level. But yeah, on occasion, if you come off weekend nights or whatever happens, and orthopedics is amazing. The opportunity to operate is fantastic, and often you don't want to miss that chance to work with your boss. So sometimes it bumps the numbers up a little bit.
I think that's the added element which you need to consider as well for a career in surgery, because it's dependent on when does the operation finish, and obviously each case presents its own difficulties as well.
Absolutely.
So you might be there till ages. We've had even when I was doing colorectal, I was working with a colorectal surgeon. Ended up staying there till midnight. Had to come in the next day. So that's crazy. What's the longest individual surgery which you've performed?
I was in a 6-hour case during my F3 year that was probably the longest, and my goodness, I felt it. That was probably 6 hours is about the longest.
In your F3?
In F3, yeah.
Okay, fine. That's also long. Were you contributing actively? Or?
Yeah. It was a complex case. It was both femurs were broken and the forearm was broken, and the patient was stable enough to let us do everything. And it was overnight as well. So we started at midnight.
Wow.
And you feel it. Wow, you really feel it at the end of it.
Yeah. Your legs start becoming wobbly. Start becoming jelly-like. Yeah.
I hope you didn't have to cycle home after that one.
I crawled to bed, man. Yeah.
What's the longest you've gone without sleep between shifts?
Without sleep, probably 24 hours. Probably 20. What does that make? 36. Yeah. So you go straight through. You don't sleep overnight, and then you carry on. Sometimes but I have to say, in the NHS and the way that consultants look after us, that's probably volitional rather than forced upon me.
Agreed. Yeah, quite protected.
To be honest, I can tell with David, this whole endeavor of becoming a surgeon is volitional rather than forced upon him. And that's another thing which we want our viewers to take into account is the passion. And we feel that any form of life, any walk of life, whatever you do, it's important to have passion for it. And that aids excellence as well. We see this when David's interacting with his patients as well, and all the experiences that we've had. We'll touch upon it later. But for sure, that's something special, which is there for many surgeons. We do actually experience that. They love their job. And a lot of them say that, I get to be paid for doing what I love. So that's actually amazing. Okay, so what's the most number of cases that you've done in one day?
Boxing Day just gone, we got through 6 on a Boxing Day, which is it's unusual. I think people were quite keen to get the work done and go home, and there just happened to be loads of people. And at Christmas time, nobody wants to be in hospital, but and I'm not sure whether you've worked in there, but when you're in there, it's nice. As a background level, like people get on. At Christmas time, everyone just wants to club together. Nobody wants to be in there longer, but equally, you want to do the very best for the patient. So I think we got through 6 in a day, which pretty rewarding at the end of it.
Yeah,
amazing.
That is a lot. So was it on? It was an on-call shift, I'm presuming.
It was, yeah. I can't remember, was it a Sunday or a Monday it fell on this year? Yeah, I think it may have been a Monday. It was.
So those 6, that would take you literally from the beginning. As soon as you literally get in at whatever time, 8, 9, you scrub in, and you're there until the end. Probably did handover in theaters.
Yeah. So we know what we're going to operate on by and large.
Okay.
And that means that you can start preparing generally the night before. You just have a look. Now, there's some things that you do very often, but you still have to make sure that you modify what you do. You could have done 100 of a certain procedure, but you have to think about the individual patient factors, what they need. So when you say we come in and scrub in at 8 o'clock, 9 o'clock, we got to get in at 7. You got to see everybody before handover. You have to see them. You have to have an idea of who you're operating on, why you're operating. And the great thing about that is the better you know the patients, the more your consultant or the registrar, if you're an SHO, will let you do. So
that's amazing.
That's
it's a useful
point,
thing,
actually. Yeah, doing your sort of background research, so to speak.
There's a lot of a lot of people in the community. They will say that orthopedics doesn't have many patient-specific factors involved, or it doesn't have that much patient rapport or communication or particular nuance to it. But they may see it as just repairing bones or more brute work. But actually, David's mentioning the importance of seeing the patients in the morning, actually seeing them, and that's something.
And the other thing to touch upon what David mentioned is that it just shows you no two patients are the same. Everyone has their own unique factors. Comorbidities obviously will change the way you approach a surgery or the way a surgery goes. So that importance of going to see the patient and not treating two sort of neck or femur fractures as the same thing is extremely important.
massively. Yeah.
Imagine you don't know the comorbidities or anything. Like the first time, obviously, you don't want the first time that you've interacted with the patient to be, when you're holding the knife at the end of the day.
Or the anaesthetist. They're the ones, because you're going to do a brief and they're going to say, okay, comorbidities.
Yeah.
And if you don't know, you're like, a bit of hypertension.
Metabolic syndrome.
Yeah, exactly. Yeah. So it helps to, and you know what? It doesn't have to be that long. Come in, check what's happened, have a look at the notes, have a chat with the patient, and they know. And it's useful.
Yeah, that's another thing I learned from David with regards to efficiency with seeing patients on call.
Yeah.
You can really still do a tremendous job while maintaining that exceptional efficiency. Amazing. David, has your team ever lost a patient during surgery?
Not anyone that I've directly operated on during surgery. People pass away afterwards, unfortunately, but thank God, no.
This is a question that will probably help a lot of budding surgeons sort of make the choice. What's the most difficult part about being a surgeon, would you say?
The most difficult part is understanding that you're embarking in a way of life which is going to stay with you for all of your working life. And I think that an understanding of your lifestyle will change, your family commitments will change, your free time will change. Everything has to be not sacrificed, but you have to make adjustments in your life, I think, to allow you to be as good as you can be in that certain field. And as long as you know that's what you want to do, and for me, it was obvious the first time I walked into surgery, I was like, it blew my mind. Absolutely blew my mind. And I think as long as you understand that, it means that when it gets tough 2 years in, 5 years, 15 years in, you know why you chose that career path and you can stick with it.
Exactly. We had on a previous podcast, we had one of our good friends, Dr. Abdul Karim. He's a teacher and a lecturer at Cambridge, and he's also, I think, an F2 now. So it just shows you that's just a small part of what he's achieved so far. And he was touching on the same concept. And there's a very important proverb we touched on that podcast is, if you know the value of what you seek, then insignificant will be the sacrifices you will make to achieve that goal. So similar to what you mentioned, like if you know truly that surgery is the path that you want to go down and it's the ultimate career for you and your dream career, then the sleepless nights or the time that you have to sacrifice, your weekends, will just be insignificant at the end of the day.
You don't mind it, and the reward from whenever things do work well, it's untold.
That's beautiful. Thank you so much for that. I wanted to ask David, do you ever get nervous before a surgery?
Very, very often actually. Yeah, but you have to not hide.
I wouldn't expect that from you. I'm not gonna lie. Obviously.
Yeah, but I think some nerves are good, right?
Yeah.
There's that whole U-shaped curve. You can't be shaking like a leaf. But equally, you can't kind of rock up 10 minutes late, like just check what's happening. And you have to that right level of nerves. But particularly if it's something you haven't done often or haven't done before, and you're trying to learn it, particularly if every patient's treated a certain way, but when you operate on a kid or a very, very old person, and it's a high value operation, for sure there are nerves in that, but they're useful nerves, and if you can control it, it's use it to your benefit.
That's why they say like some stress is good stress.
You need
like you need that balance.
Yeah,
you don't want to be too stressed where you can't function, but also you don't want to be completely relaxed. There's a specific balance that you need, which is very important. What's the worst injury you've seen so far in your career?
The worst injury. You see when you work on a trauma unit, so my rotation comes out of the Royal London Hospital, so you spend some time in there, and
you graduated from Barts as well, so
okay, so you guys know, right? So and the trauma calls there, you see people come in arrested, peri-arrest, arrest, and one thing really sticks in my mind. It was a really tough case. Like, normally the mentality of surgery, you can compartmentalize it, get on, everything's fine. I vividly remember it was a Sunday morning, handover at 8:00. Just before it, the trauma bleep goes off, which means something's coming in, get down to resus, and then it's a code red, which is an added level. And they've had blood products outside of hospital, or it's been cardiac arrest, and as it happened, it was somebody who had unfortunately taken their own life.
Okay.
And they came in, and it hit me so hard because he was exactly the same age as me, like literally to like a month or something.
Wow.
And there was obviously so much that they had going on in their life, and that it makes a big impact. I remember going back up to the trauma room, and it takes a long time to process it and to think about it. Some people like to talk, some people don't like to talk. But that was, when you talk about injuries, that's that is the end. It's the worst that you can see.
I think that paints a profound picture of medicine and the career pathway as a whole. First of all, the fact that David had to go and process all of that emotion, but the added element of for you to be in that position of where you can be responsible to aid someone who is reached that position of his existence where he wants to take his own life. All the problems that he's dealing with, and to make him reach that position. But like, it's a big responsibility, and I want us all to just really reflect on that position that we are placed in within society. It's a big responsibility for caring for people at their worst times and in a difficult state, and I think that cannot be understated enough. I think every single day when you're going to work, I think that mindset needs to be understood and truly internalized in order to provide the best possible care.
For sure, man, 100%.
Definitely. 100%. Yeah.
What's the best advice, David, that you've received from another surgeon? Obviously, we understand that, especially with all professions, but especially within the field of surgery, it's all about mentorship and about learning from your seniors, taking from them respectfully in the best possible way. But I'm sure you've had a whole load of consultants who have shaped your journey, but what's the best one advice which you've received from another surgeon?
You're right. You pick up different things from everybody. The single best bit of advice was probably from a transplant registrar. Whenever I was a medical student and I was super interested in surgery, wanted to do it, and I spent a 3-week attachment with them. And he said, decide what you want to do and don't let anybody hold you back from it. And it can sound flippant and it can sound quite easy to say. It's much harder to do, but taking it from somebody who has done that, and I followed his journey, and he's a really successful transplant surgeon somewhere in the UK, and when they do that and you follow what they do, you can really believe in it. So to begin with, you think, okay, that's fine, I'll stick to it. Then you just pick what you want to do and go for it. Don't let anyone tell you it's too competitive or it's too difficult or you can't do it, or no, you stick to it, you go for it. And then to watch them flourish in their career, then it gives you more confidence in what they said as time's gone on. So
that's very, very uplifting, man. I think you need this, like I think we spoke about in a previous podcast, you need mentorship and you need people that will uplift you, especially when you're your role models. If you've got people that you look up to, and they give you sort of words of encouragement or kindness, or even like I remember scrubbing into certain surgeries when I was a medical student, and then you'll do something that you'll find so trivial or meaningless to yourself, But the like maybe like just doing one stitch or something at the end of the operation, and the consultant will be there, or the registrar or the SH or whoever it is, and be like, well done, and you did great work today, and it sort of uplifts you. So like the power of words, and especially people if you look up to, you want to be in their position in a couple years time, it's very, very underrated, and people shouldn't underestimate it.
You're so true. And is the old saying, like, no training today, no surgeons tomorrow. And you think it's difficult, right? It's difficult for mentors and trainers. And as I progress, I'm beginning to understand just how difficult it is to let somebody else do an operation. For years and years, I've been wanting to do it or being taken through it.
Yeah.
And now in some cases, you get the chance to take somebody else through, maybe through a DHS or a hemi, like a half hip replacement for fracture.
Yeah.
And my goodness, when you're on the other side of the table, letting somebody go ahead with it or stood over their shoulder, it takes a lot. And so it really makes me value those mentors that I've had and really, really look up to what they've let me do.
Yeah, that brings us on to my next and final question, David. Coming on to the point of the difficulty of letting another individual, another junior that's under your wing, take a surgery or guiding them through it. Are there any particular surgeries that your favorite surgeries that you don't want anyone else to sort of
come and have a go at?
Yeah.
The majority of your training as an orthopedic surgeon and in the junior years is based around trauma. Elective surgery takes, in general, more training. People are well to begin with. They come into hospital to be made even better. Trauma patients have had a significant trauma, and you do everything you can, but just the nature of the way our system works, you get to do more trauma in your junior years in general. And I love doing a femoral nail. Like a femoral nail, it's so satisfying because they can't walk in. Generally, you do an operation within an hour, 2 hours, whatever it takes, and they can sit out the next day and they can ideally walk home afterwards. And even when you look at a femoral nail, it's a proper bit of kit, right? It's got the science, the technology, the engineering into that implant and how it works. But as much as I love doing it, it's more important that when it's the right case and the junior is able to, that they get a chance to do it, even part of it. But you have to try it, because once your hands are in there and you're doing something, as you guys have said, you feel it, you enjoy it, and you want to do more. And for some people, they'll do it and they'll think, fine, I've done one, but never again. For some guys, they look at it and they think, that's absolutely what I want to keep doing. And if you can give people that opportunity, like I said, it's one of the most enjoyable bits of training, because you know that you've shared your passion for it with somebody who may take the same career path.
That's amazing. I think there's a very important human element to it as well, because you're not just telling someone the recipe or the instructions, but as Zach mentioned, it's that companionship, that mentorship, and that encouragement, is that you're working with someone who in and of himself is going to do thousands of cases later on. So if you just think about the sheer impact of teaching one individual surgery, and that ripple effect, which the good which you're doing for society, can then be multiplied through different people all across the globe. And that person himself will then become a teacher later on. So that's actually profound. I think that's another area just actually dawned upon me, how as a surgeon we often think about legacy and things that we want to leave behind, like we want to leave a good impact on the world. But if you're teaching another surgeon, then that's actually extremely profound, because years after you're gone, then that good which you've left behind is actually still there. So that's actually an amazing reflection and just dawned upon. So David, I just wanted to discuss with regards to the your background, like your medical school background, like what made you decide to pursue medicine, and then we'll go into the orthopedic specialty a bit later on as well.
Sure. I left school with an average bunch of A-levels, and medicine just wasn't anything that was even on the cards for me. If we go back, I struggled at school quite a lot until my A-levels, and then I realized I was dyslexic.
Okay.
And as soon as that happened, as soon as that switch was flicked, everything just transformed. And then I did my first degree at Loughborough in sport and exercise science, which is a difficult enough degree to get on. I think it was straight A's at the time, and I managed to transfer after a year on a similar course. And as I went through it, I had a good friend who was studying medicine, and I realized there was a lot of crossover between the sport and exercise elements, the health promotion, the physiology. And then I thought, well, what if I was able to do medicine? Could I do medicine? You know, it's always thought of as a maybe an elite career, or, you know, it's very, very esteemed in society. And it was never something that ever crossed my mind. And as I looked into it and read and realized what you could do from the career, I thought that's for me. So I did my first degree in sport and exercise science, and then went straight into graduate medicine.
Amazing. And this is actually, it's interesting hearing your story, because I hadn't known that that's how you got into medicine via that route. Because everyone that comes onto our podcast, everyone has their own way, or either first what sort of drove them into applying into this career and embarking on it, and also secondly how they got in. I mean, we had like one of our medical students, Costa. He applied from Cyprus, and obviously he was diagnosed with a brain tumor very early on in life, and then that drove him into and sort of shaped his career, and how he got into medicine. So everyone's different, and I'll say the message that you can take away, or a good learning point from this, is to show viewers who are maybe thinking about applying. Some people may think, as Dr. Karima said, one of the medical registrars we had on, he said that it's never too late. Like, don't feel as though, even if you've done a degree, don't feel you can't still go into medicine after doing that degree. Like, there's always an opportunity to get in, and to just go for it. If it's something that you want to do at the end of the day, you need to go for it. Similar to what the advice that you receive from the transplant surgeon. Don't let anyone ever tell you that you can't do something.
100%, Zach. And I think what's profound as well is that doctors come in a wide range of phenotypes. And first of all, my first reflection is the fact that a lot of people who are interested in sports, they're naturally interested in the body, the way it functions, human physiology,
anatomy,
and they often enter medicine as a kind of carryover of that interest, that passion. But then the other thing is that obviously it's very interesting to hear from you that you had a sports and exercise background, and now you carry that over into orthopedics. So you clearly had that element of interest in function, the way the body works, and that carries over into even the very nature of the diseases which we're dealing with in orthopedics as well. But it just really goes to show that point that we regularly mention in the podcast, is that a career in medicine will allow you to find your particular niche depending on your personality type. We've already discussed the radiologists, maybe of a different character, people who work on the sports pitches, maybe on a different character. The intensive care doctors may be of a different nature, and the problems you're dealing with as well are of a different kind as well. So for example, in the geriatrics ward, we have a different pathway. The length of time the patient actually takes for recovery might be different. The communication styles might be different as well. You may have to find yourself speaking a lot louder to patients who may be hard of hearing, There's so many different variations and intricacies, and that's what I'm just so passionate about exploring and, hearing these wonderful stories. So that's amazing, David.
We're so fortunate in medicine, right? It's so vast. You think, I'm going to be a doctor, but actually the spectrum of that, and also, you don't have to go straight through and become a GP or straight through and become a consultant. There are other things that you can potentially go and do. So I think it's, for anyone looking at it or interested in it, it is a phenomenal career choice.
Yeah, for sure. 100%. The options are endless. What you can go into, where you can end up specializing. So you went to Loughborough, did sports and exercise medicine. Then what medical school did you go to after that?
Leicester.
Yeah. So how was it studying in Leicester? What's the city like?
Leicester was good. Do you know what? It's close to Loughborough. Yeah, it's close. So I kind of, you maybe go there for some evenings or weekends. And they had, at that time, I wanted to be a cardiothoracic surgeon. And they had a great cardiothoracic unit. And it just seemed like a real natural progression. I enjoyed Leicester, made loads of friends, had a great time. Medicine, it was an accelerated course, so you do 5 years work in 4 years.
Okay.
And it's you have to work pretty hard for the first year and a half.
Yeah.
But you're with a group of people who are all experiencing the same thing. And it's like anything, you join together, you have camaraderie, you get through it. And it was very good. It was Loughborough. I don't know whether you guys know, but Loughborough is an unusual university. It's very, very sport based, but they also have a huge, big engineering aspect and increasingly social sciences. But not everyone, but many people are up at 5, 6 o'clock in the morning out training, running or rowing or doing something.
Brilliant. That's brilliant.
That's a very good environment to be in.
It's very different than most universities. So Leicester was very relaxed in terms of that kind of bread and butter environment. And Loughborough is great. You sit beside some people who one week are with you studying, and the next week they're off at the Commonwealth Games, or they're going and doing something amazing in their career, or playing very high level rugby, or whatever it may be. And the chance to study in that environment, it very much helped shape my view of what's possible and what you can do.
I'm actually interested to ask this question, is that does your physical background or physical foundation aid you with the endurance of the physical demands of orthopedic surgery as well?
Without doubt. And my dissertation at Loughborough was having a look at carbohydrate drinks, and when you cycle to exhaustion, does having a amount of carbohydrate in a drink mixed with electrolyte influence your performance? And it's pretty brutal. I don't know why my friends ever volunteered to do it, but you had to come into a room probably like we're in here. You chill it down to 10 degrees. You get them to swallow a thermometer the night before, so it's measuring your core temperature as a marker of exhaustion. And then they cycle at 70% of their maximum performance until they fall off the bike.
Wow.
And they come in 1 week and they drink 0% carbohydrate, then 2, then 4, then 6 every week. And you measure when they fatigue. And it's interesting, like carbohydrate drinks work, and they work really well, and there's a really measurable response. But when you're studying that kind of thing as your first degree, it helps you understand human performance, what influences it, what doesn't make any difference, the psychology of it as well. And definitely for surgery and for some of the longer operations you have to do, there's a whole way of preparing yourself and being ready for it. And you don't have to do that degree before, definitely, but there is useful stuff that you carry over.
Okay,
that's so interesting.
Yeah, that is interesting. What are some of the things then you would advise, like to prepare before long surgery? Like, what would you steps would you say to tell people to take?
So obviously, there's all the prep before, so know what you're doing, know why you're there, know what the end. If you know as a team what the end result is, you're replacing a hip, we're going to decompress the spinal cord, whatever it is we're going to do, then that's key. When you're getting ready to go into theatre, the most important thing is go to the toilet.
Okay. empty everything.
Because you don't know. So try and have had something to eat and drink before. Make sure you're ready, because a 2-hour operation sometimes can turn into a 6-hour. Yeah. It's rare. It's rare that it happens, but when it does, my goodness, you're grateful that you've prepared. I remember as a medical student, we were doing some laparoscopic resection. I had no idea. I had no idea what I was going in to help, but I was the retraction guy, and my goodness, at like 4.5 hours, I could really start feel myself starting to sway, and like I didn't know where I was or what was happening. And you make the mistake once of not eating or not doing it. So be physically prepared, and then also, we don't just do one operation. It's rare to do one. You have to be prepared to focus intensely for whatever you're doing. Come out of it, help the theatre team transfer the patient, get ready, think about your next one, have something, do the op note, and then go back and do it again. And then being able to find a way to consistently do that. It gets much, much easier as you become more comfortable and competent. But whenever I first started operating, it's, and I'm sure you guys have felt it before when you're in theatre, nothing else matters other than that tiny thing. Background noise goes out of the window. You don't hear the anesthetics machine. You don't notice people walking in. Nothing matters, particularly when you're first given the knife or you're doing it. And that level of concentration, it does take its toll, particularly at the end of the day. You're driving home or you get home, and you need proper rest. You really have to properly rest, whichever way that is for you. So being prepared, making sure you're well nourished, but also taking that time to rebuild and recharge the batteries.
That's actually profound. I mean, nowadays we have a crisis of attention spans with the new generation of, TikTok, social media. Cannot even focus for like 20 seconds or something. I'm shook for them doing the operation. But hopefully the attention spans can remain for the same. But it's just like that it's amazing, because even if you tie that into this podcast, obviously we've got the lights above us right now. We have to focus intensely for this 1 hour. But that's an amazing skill. And to be honest, like, it's more obvious in these other realms of activity. Like, for example, we look at MMA fighting as well. They have to do some proper weight cuts, and they're in the sauna before. They have to make a certain weight for the fight, and then they can finally eat after that. But just think about the surgeons as well. He's making sure that am I hydrated enough? But at the same time, not hydrated too much, obviously, because obviously you mentioned the toilet factor. But there's also the other element of what's my blood sugar level like? Am I gonna be close to passing out in this particular operation?
Yeah,
there's so many different factors, and that's actually very insightful that you mentioned that.
Yeah, David, you mentioned that you wanted to do cardiothoracic surgery when you were in medical school. When did the transition happen to orthopedics, and why did it happen?
The first year of medical school up at Leicester, I managed to find a way to get into cardiothoracic theatres at a weekend and just see what they do, because I thought it's important if I want to do it.
Yeah,
cardiothoracics, it's like neurosurgery. They're orthopedics is quite encompassing, but in general, I think we're relatively well balanced. You have other things. Cardiothoracics and neurosurgeons, at least for me, and the way that I viewed it, is that's a completely all-encompassing lifestyle choice, much more than this. And I watched what they did, and I followed a few surgeries and followed a few patients, and it seemed really interesting. But I happened to pass by an orthopedic theatre, and I can't remember how I ended up in conversation or being in there. But by the second year of medical school, seeing what they did and understanding the impact they had on patients' life, I knew it was for me. And it's really simple. The first one, an elderly lady came into hospital. I think I had some I can't remember how, but I had some exposure to the orthopedic team. I vividly remember she couldn't walk into hospital. They did a DHS. I had no idea what a DHS was, but I was in theatre and I saw them do it, and you see the X-ray and you see what happens at the end. And then I remember seeing her in the ward a few days later, and she walked home, and that made me think that area of medicine was absolutely what I wanted to do, because directly with your hands, you can have that effect where they can't walk, they're walking, and whatever variation of that it is. Cardiothoracics, amazing, unbelievable doing that. And I had a core surgical job in that at Bart's, which was brilliant. But I just knew it wasn't for me, that way of acting and setting up your entire life in one way. So I made that decision at second year medical school.
Oh, wow. Yeah, that's good, because I was quite interested when you mentioned cardiothoracic surgery. Obviously, my initial thoughts were that you went to Loughborough, you did sports and exercise medicine, so it's a natural transition when you go into medicine that you'll probably be interested in orthopedics. So then when you mentioned cardiothoracic surgery, I was like, that's a massive transition, obviously transitioning from that and then decided to do orthopedics. So yeah, it is interesting. So I'd say then your choice of becoming a orthopedic surgeon was pretty much early on in your medical studies, right? So what would you say you did for your second, third, fourth year to prepare you for orthopedic surgery? What advice could other budding orthopods take away from this?
I had he was an F2 at the time called Dave Clark. I think he's down in Portsmouth somewhere, but he sat me down as a second year medical student, and I've still got the piece of A4 paper that he got out. And he said, okay, you want to do orthopedics. This is everything that you need to do for the next 5 years until you're at an F2. And I remember sitting with him, and he did everything. You have to do these number of audits. You have to do this research. You have to do this additional element. You have to think about doing a master's. You have to think about doing this. And I remember looking at it and I'm thinking, I'll be grateful if I can pass medical school. If I can just kind of get out and get a job, that would be fantastic. But him taking that time to sit down and to write it out, I thought, you know what, the guy's given me time.
That's so helpful, man.
Let me follow it. And I did. I think if I still got it, I ticked off everything that I did. And at the time, I thought, can't do it. It's impossible. Definitely not. But, you have years to do it, and you have a way to set it up in your medical student elective and which jobs you get. And his advice has paid dividends, because I followed it, and it put me in a position when I was applying for jobs to be ready. And I'm so grateful for him for doing that to me. And when I get the chance for people who are interested, I want to try and give them that same support.
I can only imagine, man, because now we're F2s, right? And I realized how much time I had in medical school. Like you end up realizing, especially when you're on calls in hospital, the rota sometimes can be a bit brutal. You realize how much time you still had. And it's so especially early on when you're in second year medicine, you've got ample time. You've got 3 years before you've even graduated. So the fact that he actually gave you pretty much a checklist, that's so useful.
It was nice. And remember as well, as a graduate, it's different. I'd done a degree. I was already older. So in many ways it's much easier to follow that because you have the maturity. I think for people coming out 18, 19, going straight into
difficult.
it's very difficult. And you know what, it doesn't matter when you choose to do it. Really, once you've decided, you could have been an F4 and F5. I had a completely different career choice, but if you decide that's for you and you know why, go for it, and you'll never regret it.
100%, yeah, agreed.
That's profound. So I just wanted to take this more into an orthopedics discussion with regards to what it actually is and just more educational from that standpoint. So with regards to the specialty, it's classified as trauma and orthopedics. So I'd just like to request if you could just explain what exactly both terms mean and explaining it in a way which kind of elucidates the depth and the breadth of different types of patients which you may come across during the specialty, all the way from a car crash to all these different types of presentations. Sure.
It's coupled presently in the UK as trauma and orthopedics, and in general what most people will do as a consultant is they will look after a on-call rota of trauma patients, but also have their own subspecialist interests. So for example, my current boss, who's absolutely fabulous, is a spinal surgeon. So he will do all of the spinal operating. He will have spinal patients who come in and he will inject the spine, or he will decompress the spine, or he will stabilize it, whatever needs to be done. And they're planned patients who he has seen in a separate clinic and who are worked up for an elective operation. So they're well when they come in with a problem and they go home again. If I fall over after this podcast on the way home, or if I fall off my bike, I'll come into a hospital with a trauma service as well. And that same surgeon or a different on-call surgeon will look after my wrist fracture or my broken hip or even my soft tissue injury. Perhaps not them directly, but one of their team when you're the on-call SHO or registrar. So there is that balance of trauma and elective for most orthopedic surgeons. And trauma covers everything from operating on children as young as maybe 2 or 3, all the way up. And we've done hemiarthroplasties or DHS fixations in people well over 100. And that having that extreme range of patients that you look after, it's reflected in the training that you have, and you'll get that full spectrum. But that's trauma and orthopedics goes everything from the car crash to the well 50-year-old who needs a hip replacement. And the breadth of what you're able to do, I think, keeps the interest and keeps the fascination. If you were just doing left knee replacements, you'd be brilliant at it. And for some people, that's the right thing. For some people, that's what they like to do. But the majority of NHS work has that trauma and orthopedic setup in it.
We actually had a few of these situations when we were on call together with regards to the adult trauma calls. So can you just talk us through what are the main responsibilities for the orthopedic team when the adult trauma call is put out?
You have to go down to the trauma bay where the patient comes into. We call it resus in the UK. And you'll always have a trauma team. So you'll have the A&E team who often will run the call. So somebody making decisions at the end of the bed. You will have a general surgeon, an orthopedic surgeon, an anaesthetist, and then all of the other people who help the nurses, some of the porters and A&E sometimes when you move in between. You have access then to a range of tests, so you can do all of your blood tests. You have inevitably some form of radiology, if that's ultrasound at the bedside, if that's going for an X-ray, if that's going for a trauma CT, which most people in a trauma centre, almost everyone will have a trauma CT. And when you guys, particularly if you go to the Royal London, whenever you go down to a trauma call, there's a lot of people there. When you go to a code red, I've got, a mental photo of what it's like. And I remember counting 50 people in that room. And they're and it's a small area. It's a bed space. And they're doing everything from looking after somebody who's got a simple broken bone or just a graze, ready to open somebody's chest and restart their heart if need be. It's very, very rare. But they have that ability, and that's what a trauma team will be able to do. And when you work in a trauma center, you see some amazing things, and how quickly someone can come in, go into a CT scanner, and be up in theatre within literally minutes. Minutes of having of arriving at A&E, a few minutes of having the accident outside. It's amazing to see what can be done in that time.
Yeah, I've been to a few trauma on calls as a gen surg SHO, and honestly, I wouldn't say there's 50, but there are still a lot of people, especially in our hospital. And I think in that moment you need a sense of leadership, similar to an arrest. It can be chaotic, people don't know what they're doing, but you need someone to, start the sort of primary survey, go through everything, examine the patient appropriately, do ATE, and then obviously do the secondary survey, and then decide on what exactly you need at that moment in time for the patient.
Absolutely. And that example of 50, it's an unusual one, but in a big trauma center, in a trauma unit where we all work, you can easily have 15 people, 10, 15 people ready for it. And you think of the resources and the time and the effort, and it's one of the amazing things about our healthcare system that no matter what happens to anybody outside, there is that team who are available for them.
I think that's absolutely profound. I mean, obviously now you're sat in this current position in a chair, in a much different environment, in plain clothes, but then it's just for the viewers to also acknowledge is that this is the same person who, like, let's say if anyone falls on the road or anyone gets into a, let's say, road traffic accident, is that then we'll be in the scrubs and caring for you. And it's just that
transition,
crazy, like oxymoronic, like this big transition, big juxtaposition of someone in this position versus someone in the high intensity, and he has to be proficient and capable in both. So that's absolutely profound.
And it's the big thing with that is the team.
Yeah.
So you on your own, you can do limited stuff, but together, and when you have all of the specialty help, it's I've seen some horrendous train accidents or tube accidents, just some of the very worst things, just because of the level of energy. And what they can do and how they can preserve, sustain, and continue life is absolutely mind-blowing.
Yeah, I can only imagine some of the stuff you must have come across in Royal London, especially because Royal London have the helipad. Yeah. So they're bringing in like big cases, like the amount of times we were inside, because our university building was quite close to the helipad, obviously the hospital, and like we'll be in like problem-based learning, case-based discussions, and you just hear the helicopter going, and then everyone just has to stop because it's so loud. And it would literally go like, I'd say once every 2 hours or once every hour or so, you'll hear it going. So the amount of cases that must have been coming into Royal London, because of big center.
They do. Yeah, and as an orthopedic SHO there, you go on to every trauma call. Wow. And after a while doing, as you guys know, doing a secondary survey, sometimes you have to always remember, particularly in the middle of the night, your 11th secondary survey, like 4 o'clock in the morning. Yeah. It's difficult. But as that trauma team, the primary, the secondary survey, and then tertiary survey up on the ward, it's amazing what can be done.
Yeah. For sure.
Just going back to when we first met, obviously, I remember you had come out of the theatres, right? And essentially, what I find very interesting about the particular shifts which you have is that sometimes you can be in a different clinic, which our clinical work is done around 10-15 minutes drive away from the primary hospital. Obviously, we do have a clinic in the hospital as well, but sometimes there's another clinic. You can be based there. You can be based in the theatres. Then you're on call. You have on-call patients to see. So it just seems like all over the place with regards to the schedule and the rota. So I guess my question is just that, like, what is the day in the life of a orthopedic registrar? And also like touching upon these various different roles which you may be handed as well.
Yeah, we have, I would say, probably 3 principal activities. The operating, which is fairly self-explanatory. Yeah. And you know, as a trainee surgeon, you would be expected to operate probably 1.5 to 2 days a week in general. And then you will have clinic activities. So that's just sat in a chair, having a chat and examining people, which is nice. You need that balance. Yeah. You need it to go against the physical side of operating. And then you also have the on-call or doing the ward round side of things. And we're fortunate in orthopedics, I think, to have very, very good junior trainees, and they're able to look after a lot of the ward work themselves. You know what it's like. If you're worried about someone, you come and you ask the registrar, or probably more often the medical registrar is who you will ask. Yeah. But we'll manage the on-call, and because we have a good team with us, it means that you can operate and you'll be an A&E and you'll see the referrals and you take them. And I think orthopedics is great because as a relatively junior doctor, you can be making decisions on treatment, start acting on them. And, you know, if it's an infected joint, it's obvious. You won't send them home. You know, if you're worried about spinal cord compression, you won't send them home. But there aren't many things that as a junior trainee you can't make a clear decision on. And if you're ever worried, you admit them to hospital and you wait till the registrar's out of clinic or theatre, or pop in the middle of it and say, you know, I've got this patient, this is what it looks like, and you show them on packs. But they're the three principal activities: operating, on call, and doing clinic work. And it's just balanced across your training program of 6 years.
I think it's good that you have that balance, as you mentioned. Like, you need, I feel like you need obviously that intensity where you're in theatres and you're operating on patients, and then also having that balance with clinics and getting to know patients. And I'd say a lot, especially as a surgeon, you know, you might feel like most of your learning is done in theatres, when in fact actually you get a lot of learning done in clinics, you know, seeing these patients and, you know, examining patients and offering your management and how to tackle these issues.
Clinic's tough sometimes, you know. They give us 5 minutes for a patient.
Wow.
And by the time
that's less than GPs.
I know, for a fracture clinic. Yeah. So sometimes, you know, on a busy fracture clinic, you have 25 patients in a session in the morning or afternoon.
Wow.
And sometimes by the time they come in, they take their coat off and they sit down and then they start talking. You're like, we're kind of 3 minutes in already. So you have to learn to become efficient. And a really good bit of advice that I had from a surgeon who's over at Imperial now is he said, learn to enjoy clinics. And if you can enjoy it, and if your patients, and actually it has a massive cyclical effect, because you're enjoying it, they enjoy talking to you and they feel more that they can relate to you and they're able to open up more. And then if they enjoy it, you enjoy it, you find a solution often a lot quicker because you're there and they know that you're enjoying your work. So I think if you can get to a point, which is difficult sometimes, on your 22nd patient of the morning with something that you may not necessarily have a clear management plan for, it's tough. But that's why we practice, and we have great support from consultants.
That's actually crazy. You know what, Zach, this reminds me of when we were in the on-calls together. And we actually went to pediatrics A&E, and I think there was some outbreak of, one of the virus recently at that time. So there was around, I think one of the nurses said the entire borough, entire area, all the kids in this area have come to this hospital A&E right now. Wow. So it was jam packed. We could barely find a chair or even a bed. Some patients we had to examine outside and things like that. But what I noticed was that even despite all of this scenario going on, you made sure to make the interaction enjoyable. So you were communicating with the kids, enjoying, making sure that they maybe even inspired, maybe they even want to become doctors one day, but just taking away the stress of the situation for the patient and just really maximizing that human interaction and that human experience. That's one of the things which I personally picked up from you, and I definitely seen you put that into practice. I think that was amazing.
Thank you. You know, if you've ever been into hospital yourself, I remember going in for I didn't really need to go into hospital. I thought I'd broken my finger. Yeah. And I still remember how the doctor treated me at that time, and it's terrible. And I decided I was never going to be like that. And I remember that 15 years later. Wow. And what we often don't think is you have 10 people on a list or 5 people to see, and your interaction with them would just be another patient, another patient, another patient. But actually, they take it away, and they'll talk about you. Yeah. They'll say, my doctor was like this, or he did that, and it's super important to give them that opportunity to express their views, interact, and if possible, one of my great mates is a great orthopaedic surgeon and registrar. He's one of the funniest people I know, and he always injects a little bit of humor, and it doesn't, for him it's natural, and it's a joy to watch. But if you can get patients smiling or just relaxed, it makes so much difference.
100%.
Yeah, I agree.
And where does that passion, like we mentioned at the start of the podcast, that you have a lot of pride for your work and a lot of value placed on performing to the best of your capabilities. When you were mentioning things like I'm on call, and you were reiterating the point that you were just taking ownership of this shift, that this is my shift, it's going to be done with excellence and things like that. Where does that stem from, and what can we benefit from that particular mindset?
Where a lot of it comes from is from realizing what your bosses as consultants do, because we talk about a multidisciplinary team and we all have a certain role in it, but actually at the end of the day, it's very often the consultant who the complaint will come back to, or the consultant who ultimately is responsible, who may have to go to the coroner or whatever it is the consultant who's ultimately the one who takes that responsibility, definitely as part of a team. And having gone through training and had the chance to see so many wonderful consultants, you realize how they approach it. And it's not 8 to 5. At 5 o'clock you go home, it's finished. You've operated on that patient, or you've seen them in A&E, and you hope you've made the right decision. You've done all the reading to make sure you have made the right decision, but you're ultimately responsible, and you're responsible for all of that interaction and for everything that potentially happens subsequent to that. And you work with good consultants and registrars who take that ownership and they decide how everything is going to be. And I think for juniors as well, it helps because hopefully it empowers them as much as possible to realize it's their on call. You're seeing the patient. You make a decision plan. It might not be the right one, right? And equally, the decision that I make may not be the right decision. But if you work together, if we talk to each other, if we think about it in the broadest sense, and if you take pride in your work, then you will always be able to leave work, leave a shift, leave an operation, knowing that you've done the very, very best you possibly can. And it's a rewarding way, I think, to go about your career. It takes work. It takes hard work. And there's a fair element of stress that comes with that. But I don't think there's ever an alternative way you can be and adequately provide the healthcare that people need.
No, for real, 100%. And I echo those statements, obviously on a much smaller scale, given my experience. And
but the interactions that you will have, or the interactions sometimes that the medical student can have, and maybe having more time with somebody and giving that person the chance to speak. And you have some medical students and junior doctors, we're very hierarchical. Right? I talk about consultants, you talk about you, but actually, as a team, you're so much stronger. Be it like the trauma team, the on-call team, working together and listening to the story that you've managed to get from the patient whenever you've seen them, or that the medical student picks up, and understanding that. And it is easy to put people on a pedestal and think they're a neurosurgeon or they're an interventional cardiologist or whatever. Perhaps as a society we think of as a certain very esteemed position, but all of us in healthcare, even I spent time as a healthcare assistant, and some of the stuff that you're able to do and the human interaction that you have on the ward with people, it can change their day and help a lot. And I think medical students listening, junior doctors who aren't sure, that you value yourself and what you can bring to the patients that you see.
That is profound, man, and I think this is a boost a lot of juniors and especially F1s. I remember when we were starting F1, sometimes there's this whole, not stigma, but like, sometimes F1s can be sort of in the background and they do a lot of work, but sometimes they may go unnoticed. And we've all been obviously where we've just finished F1, we're F2s now, but I'm sure like we're all F1s at the end of the day. These registrars, consultants all started off there. So
exactly,
and even as medical students, everyone is valuable and everyone has something to bring to the table. So I think it's very, very important that everyone understands this concept, and it's a team effort, you see. So definitely. Similar to what you mentioned, like when you mentioned that as a registrar, what allows you to operate and like just focus on the operation. Sometimes Inam, if he's your SHO, he will be in ED taking care of ED referrals and also taking care of the ward patients. If that component, if Inam isn't there, likewise, if you're not there, then obviously one sort of aspect misses out of that whole system, sort of will collapse essentially.
Exactly. And Inam being the SHO, the F2 in A&E, you can theoretically do everything that a registrar could, and as well as a registrar you could theoretically try to do everything that your consultant would. And I think often if you set yourself up and if you plan your work around that, you want to try to, and my boss says the same thing to me. He says that you have to think it's your operating list, you're responsible. He is there the whole time. But if I am able to set everything up, brief the theatre team, see the patients, do it, and do the operation, at some point, hopefully I'll be a consultant. And, hopefully as an F1, I would hope to be an F2. And it is possible if you look one step ahead and aim to do that, obviously within a safe framework. You're not going to take silly decisions. But the more you look at that and the more you plan, the more enjoyable the entire environment is, because the the people are senior to you see you grow, and they know that you understand what you have to do next.
Yeah, amazing words of advice. Just to sort of, because I'm quite conscious of time, David, we're going to try and sort of merge two questions in one, just to end off, and I think it will be a good sort of end to the podcast. And obviously you've discussed that from our viewers and also myself, the understanding that we gauge is that you're sort of into your sports, you're quite a sporty person, and it's important to sort of do stuff like this and have extracurricular activities, and it's important to sort of maintain your physical health, especially as a medic or as a doctor, as a surgeon, essentially, as anyway in general, but more so because our on-calls are quite ruthless, and sometimes you can be consumed by work and you sort of forget to take care of yourself anyway. So what advice would you give to other aspiring medics, other surgeons, maybe other registrars, your colleagues, anyone? What advice would you give with regards to ensuring that you have this work-life balance where you're also ensuring that, let's say if they're into sports, that they take time out to do their sports and extracurricular activities? That's one question. And secondly, how has that changed your sort of life, would you say? So it's a bit loaded question, but
we need balance.
Yeah.
Whatever area of medicine you go into, you could end up being a pathologist and having a very different life to someone who works in A&E.
Yeah.
But there are definitely stresses in whatever area you go into. So making time to have that physical element to your life, I think, is important. Now, it doesn't have to be playing sport. It could just be simply walking and being active, or gardening, or whatever you need to do. But making the time to do that and trying to set your working day up. So I've been bad at it recently, but when I can, I try to cycle to work.
Yeah.
And actually, that's an hour of just free time. I would drive for half an hour, 45 minutes anyway.
Yeah.
So if I can cycle, it may take a bit longer, but it means that after driving to and from work and then going for a bike ride, you've made that time up. And so if you think very carefully about how you set your day up, which is very easy advice to give.
Yeah.
And it's hard when you're on rotation and you're moving one hospital and another hospital and you're moving house or whatever it may be, or you're staying late, or you have to start early. But as much as you can, try and make that time to do something and be active. And, for all of us, not surgery, for all of us in medicine, it's a lifelong career.
Yeah.
And you need to do something that's sustainable. It's fine being excellent and brilliant and putting 80 hours a week or whatever it is you're doing for a certain period, but nobody can sustain that, of course, forever. Yeah. And finding something that allows you to have that balance and make sure that you have some time away from it where you're just not thinking about it is relatively easy advice to give. Yeah. Trying to meter it out is much harder, but it's important to strive for that, whatever it may be.
Yeah, I think it's good to wind down as well. It gives you, like, when you do these sporting activity, any extracurricular activity, it doesn't have to, I say sports because obviously you cycle a lot. But it gives you the ability to sort of wind down, and it's like sometimes when you're not, it's good to have something outside of medicine that you do and you love and you enjoy to sort of free your mind a little bit.
I think we need it, and I think medicine in many ways is all encompassing. You have to pass your exams. You have to go. You want to do what you want to do the best for your patients. But I'm hugely fortunate with the people who look after my training. My training program director, he's excellent because he makes sure that you all have something, not just orthopedics, and he draws you a grid at the beginning and he tells you the importance of having balance, and having that and that understanding really makes a difference. And it means, I hope, that you can continue your whole career and do it successfully.
That's absolutely brilliant. I think we're also feeling refreshed, and similar to that rewarding feeling you mentioned that you get when you take care of patients in orthopedics as well. We're also feeling that we've gained from that passion, and I think it's very important as colleagues and as medics to talk about these topics, to share that passion, because it then rejuvenates you, also reminds you why you started, and it gives you kind of a breath of fresh air when you're going back into the hospital environment, back into the wards.
Exactly.
The fact that this is a profession we love, and every day it's a blessing to be able to do this every day. Like just to give an example of myself with David on call, and this just shows that he practices what he preaches with regards to getting everyone involved. I remember even seeing the cement on my shoes from the we were doing the manipulation of the forearm fracture, right? And you hear the click, and you put the cast around it, and the patient goes home, see it in fracture clinic after a few weeks for the repeat x-ray, and you're walking home at the end of a shift like that, and you just feel internally like, okay, I've done something today, you know?
Fulfilled, yeah.
And I guess in essence, that's what orthopedics is about. I benefited tremendously today. Thank you so much. Thank you so much, David. You can make sure to follow David on Instagram, Dr._D Ferguson. Any final words from yourself?
Thank you for what you guys are doing. You know, I've when you invited me on, I had a chance to have a look at some more of the podcasts you do, and it's people won't realize, I don't think, how much hard work you're putting in, and well done. Like, congratulations for that, because you obviously like it, you're obviously very good at it, and keep going with it, because our interactions in hospital with one patient is you and a patient, or you and a doctor. What you can have, and the interaction online is phenomenal. And hopefully through what you continue to do, you can help people follow the passion and find something that they want to do with their life. So that's brilliant. Thank you, and thanks for having me.
Cheers. Thank you so much.
That means a lot. That means a lot. Thank you so much.
Thank you. Yeah, so hopefully we'll try and get David back on for another podcast, because I want to delve into your cycling sort of endeavors. But
we'll do a riding podcast.
Yeah, that's a very good idea.
Find us on www.strivemed.co.uk, Instagram StriveMed, and TikTok StriveMed as well. Make sure to subscribe to the podcast. We are putting in mad shifts to bring you the best content.
Yeah.
Until next time.